So yeah, the first abstract for the day, which we are going to discuss, is basically adjuvant radiotherapy following radical prostatectomy for localized prostate cancer. So it is a systematic review and meta-analysis presented by Bortel et al. From Brazil at ASCO Geo Symposium in January 2020. It was presented as a poster. So yeah. Now, why did they do it? So they did it because there are 7 trials right now which have been conducted in this for this particular question, and still probably we have a lot of confusion whether adjuvant radiotherapy helps or not helps, or when it should be. So that those are the pertinent questions. And so the primary endpoints that the authors looked in their meta-analysis were biochemical progression-free survival, metastasis-free survival, prostate cancer cause-specific survival, overall survival, and the side effects. So if you look at the results that they had presented in this abstract, was basically they showed improved biochemical progression-free survival significantly with adjuvant radiotherapy as compared to the expectant treatment. Now, just to clarify, what is an expectant treatment is you just observe the patient, and suppose there's a PSA rise and you are certain that there's a clinical or radiological progression, then you treat those patients locally or systemically as required, right? And so if you do that expectant management, the biochemical progression-free survival is not good, and it's significantly improved if you upfrontly do adjuvant radiotherapy, especially in the high-risk patients. Now, metastatic progression-free survival is also significantly improved, but what you see is cost-specific survival or overall survival is not significantly improved. Now, another point to note when you look at all these results is basically there was a significant heterogeneity in meta-analysis patients that they were taken from the 7 trials. And they did try to balance it out using random effect model analysis, but results still remain in favor of adjuvant radiotherapy for the biochemical progression-free survival. The rest all they have not commented in their abstract, so we don't know. We don't have the full paper available to understand what happened to the other endpoints. So what they have concluded in the abstract is this is the first meta-analysis including the 7 available randomized trials, and adjuvant radiotherapy statistically increases the biochemical progression-free survival and metastatic progression-free survival, but did not have an impact on OS and cause-specific survival. Now, taking the discussion a little deeper to understand what is happening, because you will see in last 6 to 8 months, 2 or 3 meta-analysis coming up. This Brazilian group has presented in 3 conferences, and all the 3 conferences it was treated as a poster. Before that, Artemis one was there, which was a podium presentation in ESMO also, and other Astro and other conferences as well. So why this apartheid or kind of result? Because there's a difference between the 2 meta-analysis and the results that they're presenting. So let us look at first what are the baseline 7 clinical trials we have. So the ones with the red on the right hand of the slides are basically the historical ones, and you can see the dates between 1990s to 2005 they were conducted, and eligible criteria is almost similar, except that it is mainly margin positivity or pathological stage 3 or above. Right now, dose of radiotherapy is almost similar. The main thing that you have to understand that these all 4 trials, it was basically adjuvant treatment versus expectant treatment, which I just said to you. Now, when you read individual trial of these, you will see that around 30 to 50% of their patients, depending on each trial, received salvage radiotherapy or later on the observation arm. And that radiotherapy was given around the PSA, median PSA of value of 1, right? So this is important to understand when we talk about the newer trials, okay? Now, primary endpoint in each trial was different. So EORTC is progression biochemical free survival, the SWOG is metastatic free survival, ARO is PFS, and again finishes biochemical progression free survival. Design is almost similar, so let us take it as similar. We don't differentiate there. But if you look at the key results, what we know of today is both EORTC and SWOG showed improvement in the overall survival, but ARO and finish did not. And if you look at the sample size, EORTC has the maximum number of patients, which are 1,000 patients, as compared to it will add up to rest remaining 3 of the trials. Now, what are these newer trials, or which are in the white or left side of the screen? These are the recent trials. They have just finished accrual. We do not have their long or even short-term outcomes available in literature as a full paper. What is available is basically abstracts presented from the Radicals RT, and we have an Artemis, this meta-analysis, which comprises only 3 trials, which was actually pre-accrual. They got together and said that we will pool the data of the 3 trials to look at the long-term outcomes of progression-free survival and OS, because individually these trials may not be able to answer that. The second difference we have to understand is the 2 of these trials having an ADT additional to hormone therapy additional to radiotherapy also. And the third is they are not basically comparing expectant treatment versus adjuvant. They are comparing adjuvant versus early salvage. So in expectant treatment or the older trials, they were given, around 1 or 2 as per the, local tradition of that place where the trial is being conducted. Whereas in these trials, there are specific endpoints of PSA which are achieved, which is 0.1 or 0.2 is the value when you give an adjuvant radiotherapy or salvage radiotherapy. So there is going to be a difference between the outcomes as well as the kind of approach you will get. So what we know from the Radicals abstract that was presented in ESMO was biochemical progression-free survival also is not different when you do a early salvage versus you do a adjuvant radiotherapy for all. And that the separating line becomes basically the toxicity, because if you're giving everybody the radiotherapy, the number of people getting toxicity will be higher as compared to when you're just salvaging 30 to 40% of the patient. So till now, at 5-year median, only 30% of the observation patients or the early salvage has been given to them. Rest 70% have not needed the salvage radiotherapy. So this is one of the older meta-analysis which included the first 3 older randomized trials. And what you see here, another important point is improved survival outcome is at 10 years, not at 5 years. Similarly, cost-specific survival and the metastatic disease-free survival also improves at 10 years of follow-up median, not at 5 years. Whereas local control and biochemical progression-free survival improves at both 5 and 10 years of follow-up. So this is a Cochrane meta-analysis of older 3 trials. What you see again in the pictorial form. So we have to be careful when we are taking the newer trials and pooling the data based on the abstracts presented on various meetings. So that data or that outcome has to be taken with a little pinch of salt. So this is what the Artemis is thing that I was saying presented in ESMO. For the newer trials, and what you see is adjuvant radiotherapy is almost same for biochemical free survival in versus the early salvage RT. So based on this, again, just to review whatever I have said, so that there's no confusion and there's more clarity, that the newer trials have RT plus adjuvant hormone sub-randomization as well. So we need to know when people are doing the meta-analysis or their analysis, we need full paper to understand which patients have been taken and which have not been taken. Early salvage is better than the observation, probably, which was followed in the older trials, and long-term survival and long-term outcomes are much more needed to be more sureful about the results of either the old timers or the new trials, and then make a conclusion about the outcomes rather than these small spurts of abstracts which will keep on floating for next 5 years, I suppose, till we have a very large database of 4,000 patients with stringent meta-analysis. So to conclude, I would say guidelines still recommend adjuvant radiotherapy because the raves or radicals outcomes are not available in public domain with the full published papers. They have not been peer reviewed, and the meta-analysis based on the abstract will be very difficult. Longer wait is, I think, will be necessary and prudent to and the way forward. Thank you.